27 years ago, vulvodynia was this black box. It was, we don't know what this is. We don't know how to treat it, and women don't get better. If there was a discussion in residency training, that would be the entire discussion. And at that time, maybe we got 50% of our patients 50% better. And my biggest accomplishment has really been to able to smash open that box, myself and colleagues, with research so that we now know many of the causes of vulvodynia, and therefore we're able to tailor treatments.
Welcome to Balbo. Millions of women are living with vaginismus and vulvodynia, and they think they're alone. I'm Mathilde, and I spent years struggling alone until I finally got the help I needed. In this podcast, I'm bringing you the very best experts to answer every question you have. Let's get into it. Today's guest is Dr. Andrew Goldstein, a clinical professor at George Washington University and the director of the Centers for Vulvovaginal Disorders in Washington, D.C. and New York City. Dr. Goldstein is widely recognized as one of the world's leading experts on vulvodynia and genital pelvic pain disorders. He's published over 170 peer-reviewed articles and has authored multiple books on female sexual pain, including When Sex Hurts, which I've recommended several times on here. I wanted to have Dr. Goldstein on because vulvodynia is one of those conditions that so many women suffer from in silence, often for years, being told it's in their head or that there's nothing wrong. And Dr. Goldstein has dedicated nearly 3 decades to not only believing these women, but to actually figuring out what's causing their pain and how to treat it. In this conversation, we talk about how vulvodynia went from being a black box condition to something we can actually understand and treat. His treatment algorithm, which covers the different underlying causes from hormonal factors linked to birth control pills to mast cell inflammation, the role of surgery, and the promising new therapies that could change everything for women with this condition. I really hope you enjoyed this episode, which left me feeling incredibly excited and hopeful about the future of vulvodynia care. Welcome, Dr. Andrew Goldstein. It's truly such an honor to have you on the podcast, and I'm really looking forward to our conversation today.
Thanks for having me.
To start us off, can you tell us a bit about your journey into specializing in genitopelvic pain disorders? What drew you to this field and what's made you stay in the field?
Sure. Well, when I completed my residency training in obstetrics and gynecology, which was about 20,000 hours of training, we really did not discuss much when it came to genital pelvic pain. In fact, almost none. And if we talked about pelvic pain, it was mainly in regards to endometriosis or pelvic inflammatory disease. We really did not talk about vulvodynia or even the vulvar skin diseases like lichen sclerosis. Unfortunately, this was not part of the curriculum. After coming out of residency, I joined the faculty at the Johns Hopkins Medical School. And one day I was talking to the chairman, and he asked me what I was interested in. And this was about the same time that Viagra was released. So Viagra was was sort of a cultural phenomena. This was sort of pre-internet and pre-1,000 television stations. The main television stations, the comedians were for about 6 months, every single night it would be jokes about Viagra. So it was certainly sort of a cultural zeitgeist at the moment. And I sort of just said to him, sort of offhandedly, well, maybe female sexual dysfunction. And he said, okay, you are now the Johns Hopkins University expert on female sexual dysfunction. And I said, well, I don't know anything. And he goes, well, no one does, so you go figure it out.
Oof.
So that's all that's sort of how the journey began.
When was this?
This was in 1998.
Okay.
So it was a while back. I realized that I didn't know anything about this thing called vulvodynia. So I called up one of the leading experts at the time, a guy named Stan Marinoff, who happened to be in Washington, D.C., so right down the road from Baltimore, where Johns Hopkins is. And I went to see Dr. Mar, and I said, Dr. Marinoff, I could parrot one of your papers, or I could spend a day or two with you and figure out exactly what this thing vulvodynia is. I went down and started spending time with him, and it was a perfect match. It really was the things that I was interested in. And also, I thought when I was going to start doing female sexual dysfunction, I thought that I'd be dealing with a lot of women who had decreased libido or arousal issues. And certainly these are problems, but people, if you say you're willing to take care of women with female sexual dysfunction, the women who have vulvar pain, sexual pain disorders, and then pelvic pain will sort of come out of the woodwork and, uh, bash down your door because unfortunately, even to this day, but certainly 25 years ago, there were very few physicians willing or interested in taking care of women with these problems.
Exactly. Yeah, that theme of patients falling through the cracks comes up a lot on this podcast, and it's equally heartbreaking, but also what makes your work so important.
Well, thank you. Yeah, we did a study, of course. I think you may be aware of a study on gaslighting that was published this year in JAMA,
Mm,
where the majority of women who have pelvic pain have been gaslit. They've been told it's in their head. They've been patronized, told to have a glass of wine or just grin and bear it, or there's
mm,
nothing wrong with you. The
mm,
vast majority of women who've had these pain disorders have been gaslit,
mm,
and it's very frustrating, obviously to them, but it's frustrating to hear as physicians. A lot of times I spend often the first time I meet a patient, I'll spend 25 minutes sort of just diffusing all the sort of painful interactions and
yeah.
frustrating interactions my patients have had prior to coming in our door.
And I mean, you're widely regarded as a leader in this space and honestly a bit of a pioneer. So when you look back over your career so far, what progress are you most proud of in terms of how have things changed in terms of how vulvodynia is diagnosed and treated?
I think that's a great question. I mean, I think that when I went to visit Dr. Marinoff, these 28 years ago, 27 years ago, black vulvodynia was this black box. It was, we don't know what this is. We don't know how to treat it, and women don't get better. And that was really if there was a discussion in the residency training, that would be the entire discussion. And at that time, maybe we got 50% of our patients 50% better. I guess I would say that my biggest accomplishment has really been to able to smash open that box, myself and colleagues, with research so that we now know the causes, many of the causes of vulvodynia, and therefore we're able to tailor treatments.
Hmm.
So vulvodynia is not a black box. It is not something that we can't figure out what it is. It's actually different things that overlap. It's the same thing as saying knee pain. Do you have knee pain because you have arthritis or bursitis or a torn ACL or many other causes? Well, we're able to do the same thing with vulvodynia, and so we were able to come up with different treatments. And I guess I'm also very proud that in 2015 we came up with a whole new nomenclature that acknowledged all of the nuances, the associated conditions with vulvodynia, hormonally mediated vulvodynia, and that was, I think, another thing that was one of the big ones that we found out around that time, which was we realized that the association with oral contraceptive pills was the cause of vulvodynia, and how for a lot of women, and how we could another medications to lower hormones. And so that was a very big contribution, I think. We were able to find the genetic reasons for that. And that was a big contribution, I think, to the field because we were not only able to figure out the cause, we were able to figure out adequate treatments, and we were able to explain why some women would take birth control pills and other women would not take who took birth control pills would not develop pain. So it was very, very, so that was very useful. But again, we've really cracked open that or smashed open that box more than cracked open that box. I guess most recently, I'm very proud that 2 years ago, I helped put together a vulvodynia therapeutics summit. Whereas we've learned a lot in the last 25 years as the different causes, the treatments have lagged behind. So I put together, along with Dr. Jill Kraft, a meeting that was sponsored by the International Society for the Study of Women's Sexual Health, which is ISWISH, as well as the National Vulvodynia Association, as well as a really great patient advocacy group called Tight Lipped, as well as my private foundation called the Gynecologic Cancers Research Foundation. And we put together a Vulvodynia Therapeutic Summit where we got 15 of the world's leading experts on vulvar pain to come together. And the goal of the meeting was it was like a Shark Tank like experiment. Everyone had to come up with a new idea that hadn't really been studied, for vulvodynia, and your wish list of but you had to present it, and then all the other experts would throw critical acid at these ideas, and at the end of this summit, we all voted anonymously, so it wasn't just our idea, we would vote on which of the were the best ideas. And so we came up with a list that the proceedings of that meeting were published this year in the Journal of Obstetrics and Gynecology, which is our number one OBGYN journal. So again, that's important to get the message out to the world, what's going on,
Mm.
not just to the people who are practicing sexual medicine or vulvar pain, but really all the average practicing OBGYN was now aware of all of these different potential possible treatments.
Mm.
But even more exciting is that we're able to fund several research studies. And the top two choices voted by all of the experts are going to be ongoing. So the number one voted idea was on a medication called ketotifen. And ketotifen is a mast cell stabilizer. One of the leading causes of vulvodynia is inflammation, and it's inflammation caused by a specific type of inflammatory cell called mast cells, or a specific type of white blood cell. And these mast cells secrete a lot of inflammatory chemicals. They also secrete chemicals that cause nerves to grow, something called neuroproliferation. And so we believe that a treatment with ketotifen um, is would be a potential treatment for vulvodynia. It makes very good biologic plausibility, and the experience of several of the experts there who've already used it off label. And so this was voted number one, and I'm excited to tell you that we have just started a clinical trial sponsored by the National Vulvodynia Association and my private foundation to study topical ketotifen in women with vestibulodynia.
Okay.
And that trial we just screened our first patient yesterday, so in the beginning of February, and that trial is being conducted at 3 sites. It's going to be conducted in Tampa and Washington, D.C., and New York City. And so that's women with vestibulodynia, which is pain confined to the vestibule, which is the majority of women who have vulvodynia. And that trial is ongoing. Research.cvvd at gmail.com is the email if you're interested in maybe participating in that clinical trial. So that's very exciting.
Mm.
The second choice is something called racinoferatoxin. Racinoferatoxin is a very, very, very strong cousin to something called capsaicin, which is the stuff in chili peppers.
Mm.
It's what causes their mouth to burn, capsicum, when you put on chili peppers. Well, this medicine is so strong that it binds just to the pain nerve endings, and it's so strong that it actually destroys the pain nerve endings, but does not interfere with the normal healthy tissue next to it or other types of nerve endings that were responsible for pleasure or any other type of touch. So it just binds to the pain nerve endings. And it actually is so strong that it destroys them.
Hmm.
So we're working with the National Institutes of Health to do a clinical trial on that medication. Just went through the first round of the NIH approval. It got that. It had very good approval rating. Then it has to go in front of the FDA. But we're hoping that by midsummer of 2026, maybe, or the early fall, that we'll be starting to recruit women for that trial. And that's for
Mm.
women who are considering having vestibulectomy already. So people are going to have surgery to remove the vestibule because they have too many nerve endings there. So that's another very exciting thing. So these are new novel ideas and novel treatments that are not available that we think can really move the needle on the treatment of vulvodynia. In a broader picture, chronic pelvic pain, we've learned a lot about the role of hypermobility in chronic pelvic pain. We actually think that hypermobility is the biggest predictor of a chronic pelvic pain. Hypermobility causes pain in many different ways, at least a dozen reasons when people are hypermobile that they have increased pelvic pain. One of the main reasons is that when people have loose joints, they stabilize their core by tightening up pelvic floor muscles. And the tight pelvic floor muscles contributes to pelvic pain and vulvodynia. which is another segue into the fact that we are starting another clinical trial in the next coming months of a medicine called Xeomin, which is a medicine that's similar to Botox. And it's another botulinum toxin, and it is for people who have vulvodynia because of pelvic floor muscle dysfunction, hypertonic pelvic floor muscle dysfunction, so tight pelvic floor muscles causing vulvodynia. Now, we've been using botulinum toxin for vulvodynia for um, over 20 years now. I think the first patient I used was in 2004. So I guess 21 years or 22 years now since been using botulinum toxin. But unfortunately, it's not approved by the FDA
Mm,
because there have been no good randomized clinical trials. So this is really the first large-scale randomized clinical trial for botulinum toxin for vulvodynia due to secondary to hypertonic pelvic floor muscle dysfunction, and that is using an adequate dose. There have been
mm.
a couple other studies that use because people didn't know like sort of what a real dose should be. So they use very, very minute amounts of botulinum toxin, which do not show benefit. Unfortunately, that study has been used by insurance companies to not pay for botulinum toxin for women with vulvodynia. So we are doing an adequate number of people with adequate dosing, and again, it's a randomized trial. What is really nice is this trial is being sponsored by MERS that makes Xeomin. And what's amazing about this clinical trial is that even though it's placebo controlled, which means that some women will get placebo initially, 100% of women will, if you get the placebo initially, you will get the medication after getting the placebo.
Oh, that's great.
So 100% of women who are in this trial will get the medication, and it's about probably close to $5,000 worth of medication for free
Mm,
of botulinum toxin, and it's to go along with both pelvic floor physical therapy and vaginal dilator use.
mm.
So that's another. I'm excited because to talk about all these clinical trials because this is really it's a golden era of research into vulvodynia, pelvic pain, and for treatments
Mm,
because we've learned a lot about the causes, but now we're really investigating rigorously potential new treatments for this that could get FDA approval and therefore get covered by insurance companies. So if any of your viewers are interested in participating in that Xeomin trial, again, it's a botulinum toxin trial for vulvodynia because of secondary pelvic floor muscle dysfunction, tight pelvic floor muscles, then they can also reach out at that email research.cvvd@gmail.com, and we will be starting that clinical trial in the next month or two as well. So we've got really exciting things
mm.
going on in the world of research on vulvodynia. It's taken a long time to get these things going, and I'm just super excited that we're at this point that we're enrolling people in these trials now.
Yes, it's incredibly exciting to hear about, and well done for all that you and your colleagues are doing.
No,
It's truly
appreciate
inspiring
it.
to hear
Thank you.
about. How large are the sample sizes for the clinical trial for ketotofen, for instance?
54.
Okay.
54 women, which is adequately powered for statistical significance. It also is using endpoints that have already been approved by the FDA for trials in vulvodynia.
Mm,
So essentially, this is a pilot study that has been designed that if it is successful, that it's already packaged up for a pharmaceutical company to take over and put in the necessary effort to take this over the finish line to get FDA approval.
mm,
So it really is. We've packaged it up beautifully. These are, the National Vulvodynia Association, my private foundation. We don't have the funds to take a drug to through phase 3 clinical trials and then into market. We do, but we've packaged it up beautifully such that, and that was the goal of the summit, to really get pharma interest, to
mm,
get large scale interest in national institutes of health, large foundations interested in this incredibly underserved
mhm,
community of women.
mm.
really they are an army of silent warriors
Mm.
who unfortunately are fighting this battle often alone. And we need these women's voices to be heard. And we need attention paid to them and research. And again, I'm excited what we've done. We've kicked open the door, and that it goes to a point that we actually need women to participate
Mm.
in these clinical trials. It's really important because if you do a clinical trial and you have difficulty recruiting patients, well, that says something to, people who want to do larger trials and to think, okay, I want to maybe get a drug approved or a treatment approved. If they go, well, it took you 2 years to enroll 54 women, they're not interested. They're like, the market's not there. We will never be able to recoup our investment. So it really is important for, it's difficult to sometimes participate in clinical trials. Sometimes you have to drive a distance. It may cost you, some money for transportation or a hotel room. Unfortunately, we don't have the money to pay for these things for our trial participants, but we have to. Women have to meet us, halfway. Now we've had a very nice initial interest in the Ketotifen trial, and sort of this is one of the first times I've announced the MERS trial. So about a botulinum toxin. So I expect that these, people are going to participate, but I want to implore women to consider it, even if it may be a little difficult, because if you don't participate, if you don't step up, then if you expect, just your sister in pelvic pain to be the person to step up, then it just may never happen.
Exactly. That's good messaging to add here in the beginning. So I'll leave all the details for those clinical trials and how people can
Thank you.
participate in the notes and also promote it other places because I've personally been a part of another clinical trial before, so I know the value that they can serve. Okay, so let's talk about vestibulectomy. And I have to admit that when I first heard that this was a treatment option for vulvodynia, my knee-jerk reaction was confusion and maybe even a little bit of horror, because to me it felt so counterintuitive. Like, why would you add surgical trauma to an area that's already in pain? But as I've learned more about vulvodynia subtypes and the mechanisms behind the different subtypes, I've started to understand why this can be incredibly effective for a specific group of patients. Still, I think that initial, like, wait, what reaction is something that I hear from people all the time. So I'd love to start with the fundamentals in terms of what exactly is a vestibulectomy and what's the underlying surgical goal of it.
Absolutely. So one subset of vulvodynia is something called neuroproliferative vestibulodynia, which is that women have too many nerve endings in the tissue of the vulvar vestibule, the area of the entrance of the vagina. This tissue is about the size of a large postage stamp, the skin on the back of your thumb, if you look at it that way. Now, this tissue is unique tissue in the body. It is unique embryologically. That means when you're being formed inside your mom, different tissues come together and form different structures. And the tissue that forms the vestibule is unique tissue. And that's why it can respond, often in a negative way, differently to certain insults. What insults could be to chemical reactions. So an allergic reaction, you would feel it worse there, or an irritant reaction, or when you have a yeast infection, you may feel it much more there than anywhere else, than even in the vagina or out further in the vulva. Now, because of this unique set of properties of this tissue, there can be a condition known as neuroproliferation, where there are too many nerve endings in this tissue. And you can have too many nerve endings because of either being born with too many nerve endings or as the result of a severe allergic reaction or a chronic infection. Now, the latter is mediated by those mast cells that we were talking about.
Mm.
Those mast cells secrete something called nerve growth factor. Nerve growth factor causes the sprouting of new nerve endings. And the type of nerve ending that the new nerve endings are called C afferent nociceptors, and those nerve endings are responsible for three sensations: burning, rawness, and cutting.
Mm.
And so it feels like a hot knife or a stabbing sensation, but there's both a heat quality and a sharpness quality to the pain. And women can have up to 30 times the normal density of nerve endings when they have neuroproliferative vestibulodynia. So they can have a huge increase in the density of these nerve endings.
Interesting.
And unfortunately, to make matters even worse, these mast cells secrete something called heparinase. And heparinase allows the nerve endings to pierce through what is known as the basement membrane of the skin. The nerve endings are supposed to stop at the bottom level of the skin.
Mm,
But what will happen is the heparinase allows these nerve endings to go through that bottom layer, and they get even more superficial than they should be. So not only do you have too many nerve endings, now you have too many nerve endings and they're too close to the surface of the skin. And again, the nerve endings are responsible for that sensation of burning, rawness, and cutting.
mm,
And that's why women with vestibulodynia, with neuroproliferative vestibulodynia, have exquisite sensitivity. They get exquisite pain, even if you just touch them very gently with a Q-tip. Certainly, they have severe pain with tampon insertion and penetrative intercourse.
mm,
Now, we have known that there are too many nerve endings in women with neuroproliferative vestibulodynia since two groundbreaking studies in 1998. One was by Nina Bohm-Starke and one was by, I think, Hans Westrom. These studies came out, I think, both in the same month, I think in April of 98. I could be wrong, but I'm pretty close, around that or in that year, or maybe 99. We had been doing vestibulectomies, taking out that tissue for, at that point in time, about 15 years. The first vestibulectomies were done in the very early 80s. Now, we were doing it because the people had exquisite pain there, so we took out the area that. No, I wasn't. I wasn't doing this in '84. So my first vestibulectomy was in '98. But people were doing this procedure. My mentor, Dr. Marinoff, who we've talked about already, done many of these with very good success. But we didn't even know why it was successful
hmm,
because we couldn't see these nerve endings. It required a very special staining called immunofluorescence. And if you looked at a normal slide of the tissue, you can't see all these nerve endings. So when they started looking for this proliferation of nerve endings by looking at using this immunofluorescence, they saw that there was this incredible increase in number of nerve endings. And so now that explained why vestibulectomy worked. You were taking out the tissue that had too many nerve endings, and you were replacing that tissue with healthy tissue from the vagina that never had the problem.
mm,
And again, it never had the problem because it was embryologically different tissue.
mm,
And so women would not develop the problem again. It would not come back because you're replacing with tissue that's not susceptible to this problem.
mm,
So so people have been doing vestibulectomy since we're really about 40 years now. I have done, I think the most in the US, the second most in the world, to my knowledge, about 1,500, 13, 14, 1,500. I've lost count. And it is very, very successful. There is a 97% patient satisfaction with this surgery after a year. After 1 year, 58% of women who have vestibulectomies. Now, by the way, these are the numbers in my
mm,
practice. I can't tell you the numbers overall because they're slightly different, slightly less. But 58% of women have absolutely zero pain with intercourse 1 year out after surgery. 30% of women have very minimal discomfort. They just can't say it's 100% pain free. So
mm,
88% of people have minimal to no pain. 12% of people still have mild to moderate pain, but still the majority of those women, three quarters of that 12%, are happy they had surgery. And that's why we have a 97% patient satisfaction rate with that surgery. However, that surgery is incredibly painful to recover from.
mm,
So you would think, okay, you're only taking out this little bit of tissue. Why? And you're only taking out very, very, very thin. You're taking it out about 3 millimeters deep. So that's, if you think of a quarter of an inch, or if you put 10 sheets of paper, that's how thick. We're taking very thin layers. Why should it be so painful? And we believe that it's so painful for two reasons. Number one, the location. It's right between your legs. So when you move right
yeah.
here, where you're pulling on all the stitches there. So that could be one of the reasons why it's painful. Although we've certainly done other vulvar and vaginal surgeries that don't seem to have the same painful recovery.
Mm,
But the reason I believe that it's so painful is that your brain doesn't think you're taking out this much tissue. Your brain thinks you're taking out this much tissue because there are that many nerve endings.
Mm.
So there'd be that many nerve endings in this amount of tissue, not in this amount of tissue normally. So your brain thinks that it was a huge surgery. And so recovery from this surgery is very difficult. I don't ever want to put, to dissuade or, just mislead women to believe that it's not a very tough recovery.
Mm.
Again, at the end of it, the success is incredibly high, but it is a very difficult recovery. And that's why I'm so excited about this toxin study. That's the second study we talked about, because that has the potential to be essentially a chemical vestibulectomy, the ability to remove those nerve endings without the need to do surgery. And so I've always said my goal is to make myself obsolete. If I can figure out treatments for all these things, I can call it a day saying it was a very successful career. Even though I've done all of these surgeries and I do them well, and women do very well with these surgeries, then it'd be great to never have to need to do these surgeries again. And frankly, there's always a potential of a complication with surgery. Not 100% of people are happy they had surgery, 97%. I do care about those 3%. I know each and every one of them, and I feel bad about each and every one of them. And so I would love it to be in a situation where there's not even a 3% risk of failure.
So I would love to delve a bit more into patient selection, who it's for and who it's not for, because as you alluded to earlier, you've developed this widely used algorithm for vulvodynia and vestibulodynia, looking at different subtypes of vulvodynia and vestibulodynia, how they express, and the relevant treatment for each of them, which I think is so helpful for both patients and clinicians who are trying to navigate this. I wanted to step back a bit. Are you able to give us just a very high level overview of the different subtypes of vulvodynia and vestibulodynia and how you categorize them, just so we can get a sense of who this is for and who it's absolutely not for?
Absolutely. Well, so first of all, thank you for mentioning that algorithm. That is sort of one of, as I mentioned earlier, sort of one of the key things of my career was to help develop that algorithm. And that algorithm is available in our book, When Sex Hurts. So I think that's I mentioned the book, 100% of the proceeds of that book go to the National Vulvodynia Association. And I published that book with 3 additional authors, and that's Dr. Irwin Goldstein, who is no relation but a very good friend and colleague, Dr. Carolyn Call, who is a world's leading psychologist in Canada, who's just the preeminent psychologist on pelvic pain and vulvodynia, as well as Dr. Jill Craft, who was my associate and now runs this Florida Center for Vulvovaginal Disorders, an excellent physician, and she has a big a big Instagram following for a very good reason, because she's excellent. So the 4 of us wrote When Sex Hurts. This is the second edition. The first edition was very, very useful, but when you write a book, you have to live with all the things you left out. And so it was so successful, the first one, it was very kind that publishers allow us to do a second edition. It came out a couple of years ago. Now, in that book, there is an algorithm as to how you can figure out the causes of your vulvodynia. So the first thing is vulvodynia is a general category, and then there are specific subgroups of vulvodynia. The biggest subgroup of vulvodynia is vestibulodynia, which is pain confined to the vulvar vestibule. Now, that's sort of not necessarily what a woman feels, but during an exam, if you can touch the labia majora, if you can touch the clitoris, the hood of the clitoris, you can touch the perineum, even the outside part between the labia majora and labia minor, if you can touch all of those areas and it does not hurt, but it does hurt right at the entrance, then that's called vestibulodynia. Now, there are subcategories of vestibulodynia, and those subcategories are broken down into 2 categories. So on one side, you have pain that goes throughout the entire vestibule. That means the area up by the urethra, the opening of the urethra, up right underneath the clitoris, and goes all around in 360 degrees. If you have pain throughout the entire vestibule, that implies that there's a problem of the mucosa, which is the skin of the vestibule. And the three problems that can be affecting that entire area are hormonal causes, inflammatory causes, or neuroproliferation.
Mm,
Now, there really is a overlap between inflammation and neuroproliferation because it's really almost always if you have one, you have the other. So if we may be coming up with a new sort of categorization, just calling it neuroinflammatory vestibulodynia instead of
mm,
inflammatory vestibulodynia and neuroproliferation. And then there's a hormonal cause. And both those things affect the entire vestibule. And the people who have the neuroproliferative or the neuroinflammatory vestibulodynia, those are the people who are candidates for vestibulectomy. Now, if there is only pain in the back part of the vestibule, only the area that's towards the rectum, towards the perineum, then 9.5 times out of 10, 95 times out of 100, the pain is only caused because of tight pelvic floor muscles.
mm.
And therefore, vestibulectomy would not be an appropriate treatment, but treatment for tight pelvic floor muscles would be an appropriate treatment. And those treatments would be pelvic floor physical therapy, vaginal dilators, botulinum toxin, diazepam suppositories, baclofen suppositories, things to relax the muscle and to stretch the muscle. So those are the women who will be invited to participate in the botulinum toxin clinical trial that we talked about earlier. But if you have pain throughout the entire vestibule, that implies that there's an intrinsic problem of the mucosa of the vestibule.
Mm.
And that needs to be treated. Now, there is an overlap because people often have tight pelvic floor muscles if they have the neuroproliferation or because of the hormonal reason. And so sometimes you'll have to treat the pelvic floor muscles to completely get them out of pain, but you won't get them out of pain completely until you get rid of the intrinsic problem of the vestibule.
Right.
So that's vestibulodynia. Now, then there is vulvodynia, which means that the pain extends outside of the vestibule. One of those categories is clitoridynia, which is pain confined to the clitoris. Pain confined to the clitoris is caused by either nerve injury to the nerve going to the clitoris, called the dorsal nerve of the clitoris, or to the parts of the spinal cord that go to the dorsal nerve of the clitoris. So something called pudendal neuralgia, or something called Tarlov cyst in the spine, or herniated disc in the spine. Those all can cause pain of the clitoris. An additional thing that can cause pain of the clitoris are adhesions around the clitoris, where the hood of the clitoris is scarred on top of the clitoris or to the sides of the clitoris. And women can develop things called keratin pearls, which is the skin cells they can't, because there's these adhesions, these skin cells can't come out of normally. When you wash, these dead skin cells come out. But if
Mm.
there's adhesions, the hood is scarred on top of the clitoris, my head being the glans clitoris, this is being the hood of the clitoris. And what happens is little hard balls of skin cells called keratin pearls will form. And these keratin pearls can be actually very hard. And it's like having a grain of sand in your eye. So it's like the clitoris is the second most sensitive area of the body next to the cornea. It's a very good analogy
Mm.
because if you have a keratin pearl next to the clitoris, like right here, touching on the clitoris, then it's very similar to having a grain of sand in your eye.
Mm.
So that's clitoridynia. And then there are types of vulvodynia where it affects the entire vulva. Most of the time, pain that affects the entire vulva is related to nerve-related conditions, such as, again, a herniated disc, Tarlov cyst, injury to the pudendal nerve, and other things that cause pudendal nerve pain. And there are many things. And that goes back to the hypermobility, the people that we talked about a little earlier. People who are hypermobile often have tight pelvic floor muscles, but they also have tears of the hip called the labral tear of their hip, and that causes the pelvic floor to go into spasm as well as causes pudendal neuralgia. So this is pretty complicated. The algorithm explains all of these different causes. Again, you can see that algorithm in When Sex Hurts. It's also available on my website, vulvodynia.com, under publications. It's a little easier to read in When Sex Hurts, but we constantly update the algorithm. So that's available. And so women can work with their physicians or their providers, their nurse practitioners, midwives, that help figure out specifically the cause of their type of vulvodynia. And therefore, uh, tailored, personalized approach to their treatment. So again, Vulvodynia is no longer this black box. We can actually figure out using this algorithm and exam findings what the cause of the vulvodynia is, and therefore treat it. Again,
Mm.
we need more treatments. That's why we're doing these clinical trials. But that's the premise of.
So I just wanted to clarify one thing because in your treatment algorithm, you indicate that neuroproliferative vestibulodynia cases are candidates for vestibulectomies. But do you
Yeah,
distinguish between provoked and unprovoked pain cases as
no,
well? You don't.
not at all.
Okay.
Nope. I don't think there's a difference. I think the only difference is people who have non-provoked pain are more likely to have pelvic floor muscle dysfunction and central sensitization. So they have a longer recovery. But I don't think that in general, they have no less success rate in my patient population. Some studies have shown that, but I disagree.
Okay.
I
Interesting.
because I don't as soon as I do the surgery, I don't say you're done with me. We talk about success at a year, and the reason that we talk about success at a year is sometimes you need pelvic floor physical therapy after the surgery. Sometimes you need botulinum toxin after the surgery. You definitely need dilators after the surgery.
Mm.
So surgery is certainly the biggest mountain to climb, but it's not necessarily the complete end of the journey, especially non-provoked pain going into the surgery.
Okay, understood. And I think something I wanted to touch on, which I've seen come up a lot on this topic, is that in terms of success rates and recovery, some people considering the surgery worry about whether it might reduce sensation or take away their ability to feel pleasure during sex afterwards. Do you see that as a concern, or is that not something that you see in your
Well,
practice?
it certainly is quote unquote a concern. Certainly people are worried about it, but
Mm.
clinically it is not apparent because number one, you're nowhere near the main areas of pleasure, which would be the G spot, which would be the area underneath the urethra and surrounding the urethra. So that area is completely not touched during the surgery. And of course, certainly we don't go near the clitoris at all, except to remove the tissue that's painful near the clitoris, but the clitoris itself is not touched in any way, nor can we, where we do the surgery, can we damage the nerves going to these two places.
Mm.
So we don't affect sexual pleasure other than to improve sexual pleasure because we get rid of the areas that hurt. So the risk of that. The only thing that as far as that is diminished is lack of lubrication with surgery.
Mm.
So women will lose about a third of their lubrication with surgery because you cover up the glands of the opening. And so women have to be aware who are having surgery that they may need to use a lubricant. I tell women the assumption will be that you'll need to use a lubricant for the rest of your life. You may not, but I don't want you to go in thinking that it may not happen to you. Count on it that you'll need to use a lubricant. And it's not that they're not aroused, so it's really not a lack of arousal. So which is arousal is blood flow. It's just that the gland openings are covered up.
Makes sense. And one thing I also wanted to cover in terms of the treatment algorithm and the differentiation between neuroproliferative vestibulodynia being either congenital, so being there from when you're born, versus acquired, so developing it over time. I
Yes.
noticed that there's a difference in using vestibulectomy as a first line treatment for congenital and not necessarily for acquired. Is that correct? And what is the reason for that differentiation?
We found that people who have congenital neuroproliferative vestibulodynia, which we think is congenital, we don't know if it was acquired neuroproliferative vestibulodynia at a young age. There's some ideas that Erwin Goldstein thinks that possibly people are exposed to diaper creams or things like that, or even bubble baths or things like that at a young age. So it has been to the almost that you've always had it, but maybe you didn't always have it when you were born, but it developed at a young age. It's hard to know or prove that. Regardless, we found that people who we think have congenital neuroproliferative vestibulodynia have an even more density of nerve endings, a higher density of nerve endings than people who have acquired neuroproliferative.
Mm.
We have been able to treat people with acquired neuroproliferative vestibulodynia with topical capsaicin if they can tolerate it, and a percentage of these women are able to avoid surgery. It's almost an unheard of woman who has what we consider congenital neuroproliferative vestibulodynia to be treated by anything else other than surgery,
Okay, understood.
including capsaicin or anything else. We've never had.
Mm.
of anyone which we think have neuroproliferative vestibulodynia. And we actually did a study because when I talk about vestibulectomy with a potential patient, now I want to mention that only 7% of my patients we ever have the surgery discussion because only 7% of my patients are diagnosed with congenital neuroproliferative vestibulodynia. Okay, so I evaluate about 500 new vulvar pain, sexual pain, pelvic pain patients a year. And of those 500 women, only 7% would even fall into the category of being a candidate for surgery.
Mm.
So I think that's really important. And some people, I do have a little bit of a reputation of the guy, oh, he's the guy who does all the surgery. Well, I do all the surgery just because I have all these gray hairs and I've been doing it for 28 years. But we really only do about 30 surgeries a year, 25 to 30 surgeries a year. That adds up after a very long period of time. So again, 475 of my patients in that year are never even talking about surgery.
Yeah. Okay, that's a good
And
start.
that's important, and I think that's important to point out. So we've not really had any benefit for people who have, for congenital neuroproliferative vestibulodynia other than surgery. And again, my goal would be to hopefully this racinoferatoxin trial works and no one will ever need surgery ever again, but
Mm.
we don't know that yet.
So I wanted to go back to the point around success rates because you quoted this 97%, which is of course very impressive. In terms of that 3% and when surgery doesn't work out as hoped, what are the most common reasons that you see for that?
It's pretty uncommon. It's not one single answer as to why they don't work.
Mm.
Most of the time, it is that there was an underlying pudendal neuralgia that we didn't pick up essentially before surgery. And there have been a very few, thank God, but there have been people who end up with a pudendal nerve injuries from the surgery.
Hmm.
We don't go near where the pudendal nerve is quote unquote supposed to be, but every person is idiosyncratic and their anatomy is different. Everyone's person is different. And so there can be nerves where there's not supposed to be nerves that could get injured.
Hmm.
Again, thankfully, that's very, very, very rare. But I think that the main reason of failure has been an underlying pudendal neuralgia that we didn't see beforehand, essentially.
Hmm.
Also, there are people who failed because they don't use dilators after surgery. It's going to be necessary to use dilators after surgery. We've had people, it's interesting, in that one of those failures, quote unquote, in our published study, and one of the people said they were not satisfied with surgery. She couldn't bring herself to use vaginal dilators. And in fact, she couldn't bring herself to use the vaginal dilators until about 5 or 6 years after surgery. And when she got in a relationship that she thought was worthwhile to do, and she actually, at the end of the day, was able to have completely pain-free sex. And I call her my forever no, even because that's what happens with clinical trials or studies. When you do the trial, or you can't go back and change someone's responses
Hmm.
after it's published or after it's been analyzed. So she's my forever no, even though um, she would now not be in that 90, she'd be in the 97%. She'd be now be 98%
Mm. Mm.
of satisfaction. So, or 97.5 because it was over 200 women. So it would increase it by 0.5% of satisfaction. But
Mm.
regardless, the only way to have zero complications with surgery is to never do surgery, never have, so there's always a potential risk of surgery. And that's why, again, we're trying to figure out ways to make surgery obsolete. But until that's the case, surgery is incredibly beneficial. And what we're doing is taking out that very top thin layer of tissue and replace it with healthy vaginal tissue.
Mm.
Surgery is very beneficial. It's a very tough recovery. Now, I will also mention, and this is not to try to recruit patients for me to do more surgery on it. Remember, I'd be very happy if I never did another surgery as long as I live. But who does your surgery really matters. Unfortunately, this is not taught in many residency training programs. It's often not done well.
Mm.
It's done often people just take out the area in the back, the posterior, do what is known as a posterior vestibulectomy. And it's done for the wrong reason. They're actually doing vestibulectomy because of tight pelvic floor muscle dysfunction. So that's absolutely not the right patient to be doing this in. Or you're taking out the area that hurts the most, but if you don't take out the other areas, then those areas now hurt.
Mm.
So, now they're the areas that hurt the most. So unless you do a complete vestibulectomy and done exactly correctly, it's not the right surgery. again, unfortunately, I wish I could say that there are hundreds of providers out there in the country who do great vestibulectomies. That's really not the case. I think there are a dozen plus, but they're not 100 plus or 1,000 plus providers out there.
Yes.
And if you're going to have this very, you know, uncomfortable, difficult surgery that requires, skillful technique, I would implore any of your people considering, any of your listeners thinking about surgery to go to one of the real experts in the field.
That's a very good recommendation, a very important thing to note. Dr. Goldstein, thank you for taking the time to be here today and for all that you're doing to advance this field. It was a real pleasure talking to you.
It was a pleasure being here, and thanks for getting all this information out to all of your listeners. It really, there's no point in me just knowing it. It's very important that everyone gets this information out, and encourage everyone if you're suffering for vulvar pain. You're not alone. We believe you,
Yeah.
and again, we're working hard to try to solve your problem.
Thank you, Andrew.
Thank you. Take care.
I hope this conversation gave you a deeper understanding of vulvodynia, not just what it is, but how far we've actually come in understanding and treating it. What I really appreciated about Dr. Goldstein is his honesty about the gaps that still exist in treatment options and his commitment to filling those gaps through rigorous research. The fact that he's actively funding clinical trials for new therapies like ketotifen and resiniferatoxin is incredibly hopeful for women who are still struggling to find relief. If you are someone dealing with vulvodynia and you're interested in learning more about the clinical trials Dr. Goldstein mentioned, you can visit his website at vulvodynia.com or reach out to the Centers for Vulvovaginal Disorders. I'll leave all the information in the show notes. Participating in a clinical trial not only gives you access to cutting-edge treatments, but also helps advance the science for all women dealing with these conditions. I have personally done one in the past and can really recommend doing so. And if this conversation resonated with you, please share it with someone who might need to hear it. So many women are still being told their pain isn't real, and episodes like this are one way we can push back against that. Thank you for listening, and I'll see you next time.